Jermaine Timlin, official room monitor. But I'm really here to introduce our guest speakers. So a couple of housekeeping notes. First off, can everybody silence their cell phones? Secondly, the washrooms are right outside the door next to the elevator, men's and women's. There's also a water cooler there, so if you get a coughing fit, you can go get a glass of water out there. Circulating is the sign-in sheet. You are going to be required to sign in and sign out today at the session. So some of you signed in earlier, but the sign-in sheet is circulating around. So again, welcome. Our program this morning is 2 approaches to management of the chronic lumbar hip pain, the movement systems impairment, and functional manual therapy, being presented by April Oury and Robert LeBeau. April graduated from Boston University's Sargent College of Allied Health Professions in 1997 and moved back to the Chicagoland area to start her career in acute and inpatient rehab. She then took on the challenge of working with orthopedic cases at a national rehabilitation company and became the site manager at her facility. A few years later, in 2004, she decided to open Body Gears after working for a physician group. This allowed her to focus and achieve the highest standards of excellent patient results through one-on-one care. Throughout her career, Ms. Oury has sought to increase her manual therapy skills. She obtained her integrated orthopedic certification in 2000 through the University of St. Augustine and the Institute of Physical Art. In 2003, she went on to complete her functional manual therapy certification from the Institute of Physical Art. Then in 2009, after a year in Steamboat Springs, Colorado, and you're coming to our cloudy Midwest, she obtained her fellow status in the American Academy of Orthopedic Manual Physical Therapy. Our second speaker, Bob LeBeau, recently achieved the status of Fellow of the American Academy of Orthopedic Manual Physical Therapist from the University of Illinois at Chicago. He graduated with honors from UIC with a bachelor's in physical therapy, and in 2004 he was awarded the distinction of Board Certified Orthopedic Clinical Specialist by the American Board of Physical Therapy Specialists. Bob began studying with the Institute of Physical Art in 1999 and achieved the status of a Certified Functional Manual Therapist in 2008. In 2009, he began teaching with the Institute of Physical Art in the Functional Mobilization and Back Education courses, as well as training core first strategy classes. Bob is also an APTA certified resident instructor and is currently pursuing a Doctorate of Science degree in orthopedic physical therapy from Texas Tech University. Let's welcome Bob and April.
Good morning. My goodness, to hear all that stuff it makes me a little cringe, but it is what it is. Thank you guys for coming out this morning. I hope it will be a great course to maybe learn some new techniques, new thoughts, new theories. We're hoping to show you guys how we clinically reason through cases rather than just lecture. So this course is both a lecture, just to give you some background information on the topics, some definitions, some thoughts and theories, some things to put into your brain before we go on and actually do some demonstrations. So hopefully it'll be an exciting little class. So the first half will be lectures. I'm going to go through my little portion and April for hers. And then we'll actually go through an evaluation and how to go forward and treat some patients using 2 different approaches. Now the discussion of 2 different topics, motor control and manual therapy. In our realm, we like to try to use both of them interchangeably, but out there in the public, you're either an exercise person or a manual person. You don't marry the two. You treat them by getting them moving, or you treat them by getting them joint moving. So is it moving too much, or is it not moving enough? So there's room for 2 of them, but I want to appreciate the controversy of the 2. And if some of you guys are big into movement therapy and motor control, you can appreciate how manual therapy might assist them. If you're big into manual therapy, you can appreciate how movement system impairment or motor control activity might be beneficial to really help your patients achieve their goals and really get good at what you're doing. But anyhow, here we are. Course objectives. Describe and define a motor control movement-based therapy program. Describe and define a manual therapy system. And there's a lot of different karate dojos out there. We're particularly representing the Institute of Physical Art out of Colorado. But again, basically manual therapy and motor control. Those are two basic topics that we got going on. And there's different karate dojos and manual or movement therapy as well. We're just representing the one down in St. Louis while we do this one. Describe and define clinical patterns, presentations of lumbopelvic and hip pain, and how the diagnosis can be addressed using both manual therapy or motor control, or manual therapy and motor control. Demonstrate two approaches, the clinical reasoning behind it. I always find it fun when I go to conferences to watch the presenters, you know, what are they thinking about, what's going on. It's fine to sit there and get information and shove it into your brain, but it's more interesting to see, why are they coming up with that? What's going on? How's that going to change my practice about how things are set up? Two approaches that we're talking about today, one being manual therapy and the other being motor control. Again, I already went over the controversy that exists between the two camps. One's more passive, one's more active. Does it hurt because it doesn't move? Does it hurt because it moves too much? Is one better than the other? Maybe in certain circumstances one might be better than the other. Some people say I could treat everything with manual therapy, other people think I could treat everything with motor control. We're going to see if that's possible or if there's a balance and a blend that can really help things along. Should they be combined or kept separate? Two approaches, manual therapy on one side, motor control on the other. If you work in a practice, a clinical practice, that there's a manual therapy guru and a motor control guru, this is probably how they meet up in the hallway. I'm better than you. So one of the big things at IPTA conference, APTA conference, whatever conference I'm at, we have to stop fighting each other and stop fighting everyone else. So these two people should turn and fight everyone else or fight the problem, the dysfunction that the patients have. And then as a profession, physical therapy will move forward. Again, stop fighting each other, maybe combine our practices. This dojo talk to that dojo, we get a really good balanced approach, really to be successful. So today I'm going to talk about motor control a little bit, and April will talk more about the manual therapy approach, and then we'll blend it at the end. Following her, based on the works of Dr. Starman down in St. Louis, had the opportunity to study with her in the fall and just be introduced to what she's got going on. I've always been leery of her approach because it confused me. All these definitions and words and wobble wobble and smasho squeezo and her funny humor. It's like, what is going on with that lady? So we invited her up to UIC a few years ago, and she gave a talk on at the manual therapy forum, and it was kind of funny. Like, how can we have this lady come up to the manual therapy forum? This is our dojo. Why are we letting this lady in? But there's some topics that we could do better at as manual therapists, or as motor control therapists could do better at if you blend the two up. But anyhow, we're going to talk about some of the work that she has. And again, I'm not professing to be an expert. This is just my interpretation. So if you guys are big MSI gurus, you can kind of beat on me a little bit, or you can help me out a little bit if it doesn't make as much sense. But here we go. The body, one of the basic premises is the body takes the path of least resistance. If you're looking at a patient who has pain with flexing, and they'll have a little bit of interesting rotation in there, you can see that they're probably not moving through a segment. From a motor control segment, motor control theory, we look at why are their muscles not letting them go on the right path. From a manual therapy approach, we're going to look at why is that joint not moving. Again, two different ways to solve a problem. Some patients might benefit from one approach or the other. Some patients might benefit from both. So the topic is that it hurts where it moves. There's too much motion, as she calls wobble wobble. Too much motion at a certain segment. L5-S1, L4, L5, up in the cervical spine, at certain parts of the hip. There's too much motion going on. So let's see if we could rein in that movement, get a little bit better control, move more efficiently by using movement science approach. Accessory motions and hypermobilities is a acute cause for tissue degeneration and injury. So too much motion at a segment causes injury. Not enough motion at a segment doesn't. So that's the big difference between manual therapy approach and movement science approach, is that in one camp is more hypomobility driven, stiffness driven, and one's more hypermobility or too loose. One's too loose, one's too stiff. Movement dysfunction is a progressive condition that leads to degeneration and tissue changes. everything tends to lead to arthritis. It's just the breakdown of tissue. Everything breaks down eventually. And as I age in my practice as a physical therapist for 22 years, I'm starting to see that a little bit more acutely. I have to make sure that I'm not breaking down, I'm not moving too much where I shouldn't be, and I move enough where I should. So this is personally an important thing for me. Basic concepts. Again, this beginning of this lecture is to just fill you guys with some basic concepts, some definitions, some thoughts, so that we can actually see it in action a little bit later on this morning. Movement that causes pain is not being performed correctly. So this is where precision comes in. If they're moving through an arc of motion and they're not using the right sequence or synergy, the symphony of muscles aren't working properly. The big muscles that are strong are going to take the lead. The little muscles that are weak are going to let things go. We'll talk about this a little bit more as we go on. So what do? We're going to stop the movement that causes the pain. Stop moving where it hurts. We're going to get the adjoining segments to move better. Now, this is something out of her lecture that I peeled off, and I said, oh, as a manual therapist, and again, guys, I carry a card that says I'm a manual therapist on me. So I'm definitely a card-carrying manual therapist. But as an evolving therapist, as a revitalized therapist, I'm trying to find the best way for my patients, and that includes motor control movement. What does that sound like? Moving adjoining segments to get things to move better. That sounds like you should go and manip it, or move it, or do something to it, soft tissue treat it, get it moving. But from a movement science point of view, we want to make sure that the adjoining segments are doing what they're supposed to do, so that the segment that's too mobile doesn't get overused, deteriorate, break down, cause trouble. So basically, keep the painful segments stable. Alright, so any of you guys who are reading the recent JOSPT, I don't even know if this one's come out or not, or if it's EPUB ahead of print, but they're talking about bracing. You know, there's a lot of debate about bracing. Holding your stomach in when you jump, if you're holding on to something in the ceiling and you jump down, if you hold a brace contraction, and again, I don't know the reference, but it just came out, you're going to have increased ground reaction forces from the plate if you look at biomechanical analysis. So if you brace, you're going to increase the load, the demand. So bracing is a part of training someone to be more stable, but it's not the end, it's more the beginning. So if we're teaching our patients to brace, 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 every time you brace, you sneeze, you brace, you lift something up, you brace, if you're looking up at the stars, you brace, patients are going to be compressing the crap out of their tissues, sorry, I just swore. And that compression is not necessarily a good thing either. So appropriate firing and appropriate muscle contraction is really what we're looking at. This is a little different. Anyone have any children who play the violin? So they start off squeaky as all get up, right? And as they get better and they get into high school and maybe even beyond, they sound better. Why? Because they're not pushing so hard on one string. So back to what we do as physical therapists. If we're only pushing on one string in our muscle, if we're just contracting the heck out of the rectus abdominis, or we're trying to contract the TA or the multifidus or pelvic floor, we're not appreciating the fact that you have to have delicate motion throughout the whole system. And that whole system will allow us to take force the way we should and shear the force rather than just beating on the tissue between the muscle and the joint. Oh, that's too long. Alright, here we go. So accessory joint hypermobility. From a motor control point, we're really going to address hypermobility. Manual therapy, perhaps more hypomobility. What's too stiff, one's not stiff enough. So I'm going to use the word stiffness a lot in my presentation. Stiffness in one camp is a bad thing. Stiffness in another camp is a good thing. Those two stiffnesses are not the same thing. We're not talking about the same thing. We're talking about stiffness in a muscular system that takes shock, absorbs motion. It absorbs energy so you don't deteriorate your spine. The lumbar spine is built, and we're going to focus more on lumbar spine, a little bit of hip, because this is more lumbopelvic, hip, kind of talk on how they all kind of roll together. There's interdependence between the two systems, or they're dependent on each other. The lumbar spine is really meant to flex and extend. If we look at the anatomy, the facets orient themselves very, very upright, very in the sagittal plane. It's not meant to rotate. So and how much motion at each segment, 3, 4, maybe 5 degrees of flexion and extension. L1 through 4 rotates about 1 to 2 degrees. I don't know about you, I've been working on being a great astute manual therapist, my hands are pretty good. I can't feel 1 or 2 degrees. I can feel if it's painful, the patients can. I feel if it doesn't seem to move as well on one side or the other. But 1 or 2 degrees is very little. It's not supposed to rotate too much. It's this compression of the tissue between the joints that you're really getting that little bit of rotation. L5S1 rotates a little bit more, probably about 3 degrees. Punjabi and White's classic studies, before some of you guys were even born. I was, but some of you guys weren't around for that. Basic premises what we're trying to lay down is rotation destroys the soft tissue in the joints about the spine, about the lumbar spine. Cervical spine is made to rotate, thoracic spine is made to rotate, lumbar spine not so much. So what we're looking for is length, strength, and relative stiffness. So I'm going to try to define something that really makes me interested in the Disarmament Approach, or MSI camp, is the thought of 2 springs. If any of you guys have ever been to any of her lectures, she always pulls out these 2 springs. She got these great long springs. I don't know where she got them. This is the best I could do, but it's a small lecture course, will be good to go. Different muscles pull on motion segments at different length tension relationships. April, help me out here for a second. So a little interaction here. Go ahead and hook your finger here. So this is a motion segment. So let's call this the hip. So this guy on top, there's 2 springs. You guys could appreciate the one on the left goes more than the one on the right. So the one on the right is stiffer, has more relative stiffness than the one on the left. So if this is the glute med and maybe the deep lateral rotators of the hip, and this is the tensor fasciae lata, the mean and nasty TFL. Just appreciate, and if you turn it like this way. Oh, there you go. So if we are asking the muscle to do this thing, go ahead and pull. So now you can appreciate that she's pulling toward the top spring. So what happens is as we move throughout our day, and this is a very simplified thought, but just keep this in your head there. As we move throughout the day, and April's not doing too much of a, she's going the way she's supposed to go here. Thank you. You get the idea. If a muscle is stiffer, and again, good stiffness, not bad stiff, if the muscle is stiffer, the joint's going to go toward that. The motion segment is going to, the instantaneous center of rotation is going to bias the stiffer muscle and go away from the longer muscle, or the more elastic muscle, the less stiff muscle. Different muscles pull on motions, I already said that. So, is a muscle group, and we have to look at the symphony, the horns, the violas, the violins, all those guys. We look at the whole system here when we're looking at evaluating someone's patient for pain dysfunction. Are the muscles too long? They're too short. They're too stiff, or they're not stiff enough. Now, one thing that viscerally in my stomach, I say, oh, if it's too long, you gotta strengthen it. Good. If it's too short, we gotta stretch it. Well, I don't know about that. Let's hold that thought for a minute. That's a basic premises that I had from my Stone Ages, when dinosaurs walked up and down Taylor Street when I was in PT school, right? So, wait a minute on stretching, because there's a lot of controversy on stretching. Should we stretch before exercises? Should we not? Does that help enhance it? Does it not? I think basically they're saying don't stretch before sports, it reduces performance. And stretching passively may not be a good thing. I can get you references if you want, but right now, that's just what I'm going to hang my hat on. So we're thinking about, is it too stiff? What does it mean to be too stiff? Again, not joints, but muscles. Think about a big bodybuilder, not myself, because I don't spend enough time with the health club. Big muscles there. If you take that muscle, and we've all done this, patients with like big muscles, big quads. My goodness, I'm zipped down. I apologize. Big quads. Write that up.
Swearing, zipper open.
Let's digress for a second. So big muscle guys, right? So you have a muscle that you pull on it. It's not dysfunctional, they don't have pain, but as you pull on it quickly, you're going to have a little bit of resistance. It's going to slow you down. There's this passive stiffness that we're going to look into. So just keep that in mind as we move on to the program. Not my zipper. Do muscles that are too long fail to protect the spine? There's another premises that I've got going on. Are the multifidus are they too long? are the oblique muscles too long? Are they just not ready to go? So if a muscle's too long, the length tension relationship's not there. Are they going to have enough functionality to pull itself back in line? Or are they going to not have that crosslink, that muscle biology crosslink to hold everything relatively stiff? And when I say relatively stiff, I'm talking about protection, not like I can't move, I can't get out of bed, I'm too stiff. Cars or something like that. Muscles too short, stress a motion segment. So again, if looking at the TFL with the springs there, if that muscle is too stiff, I'm talking about getting muscle stiff, that's great, but if one is too stiff related to the other one, this is all in relationship, you're going to have a joint that's moving toward it. We already discussed this. So that's just something that's just keep on your front burner for a few moments as we go through this morning's lecture. What is relative stiffness? So here's the concept. Relative stiffness. So leave it to Shirley Sharman to put another word in front of things and make us all confused. Again, relative stiffness is one muscle that is more relative, that has relative stiffness. It doesn't elongate really easy. It's there, it's protecting, it's on, it's ready to go. It will take the load. Just think about if someone comes and wants to punch you in the gut. If you have relative stiffness in your abdominal wall, it's going to hurt a lot less than if you don't have relative stiffness. An active muscle contraction, think about bracing. If we're going to brace something, we're going to stiffen the segment up. Fantastic. It's there to protect the spine, it's there to improve posture, alignment, it puts you over your axis, active readiness. That is something that we can't achieve all the time. If we fatigue, if we get tired, if we're looking the other way, if we're always having to think about bracing, we're going to compress that spine, we're going to cause trouble. So bracing has a purpose in the initial stages when muscle movement isn't automatic. It's something that's more of a cognitive. All right, I gotta go over here, I gotta tighten this muscle up. But what we're looking for is really the passive stiffness. So passive stiffness improves the length tension relationship, meaning as the muscle gets pulled, that passive stiffness resists it. So let's think about the rectus abdominis and the terminal oblique. If I'm sitting here at what we call an extension syndrome, if these muscles are very, very loose, I'll tend to go toward the stiff spring of the spinal erectors. And then you're going to have a lot of compression and deterioration, degeneration, because these muscles aren't going. So in classic theory, let's just tighten these muscles up. Well, great. But what we really need to do is power them up, train them so aggressively that they start building sarcomeres in parallel, not in series, but in parallel to stiffen that up. So my body says, oh, I don't want to go this way. I have a tight spring that's pulling me forward and in better alignment. Larger the muscle, the stiffer the muscle. I'll give you an example of a bodybuilder. Here's a student right now with the beefiest muscle. So I say, all right, look at Kyle. See this guy? Look at these muscles. That's the idea that we've got in mind. I should take my picture. So lastly on this slide is what the big dog here, the protein, the part of the body that really does this is called tighten. Tighten it acts as a spring at the end of the myosin and actin fibers. So here, let's see. Oh, perfect. It works great. So see these like little springy guys here on the end? That's tighten. The more we build up our muscle, the more we ask that to be the muscle that's on and going and doing the job, the more these guys get laid down. For each, I read in the text, for each myosin filament there, you have up to 6 tighten. So the more sarcomeres you build, the more strength training you propose for a muscle, the more it is tighten. So why is tighten an interesting thing? Because that's a spring. That's a little tightness spring. So you have more relative stiffness based on these large proteins that are in the muscle. So if we have more of this protein, we're going to have more resistance to passive elongation, more relative stiffness. So that's enough confusing talk. Why is it so important is the muscle will be more ready to protect. The length-tension relationship will be more advantageous, more beneficial. And your spine is going to move in the way it's supposed to, not in the way that it wants to. The abdominal wall has a lot of different muscles. You say, Bob, you're going to talk to us about the external oblique, how important it is. How about the internal oblique? For goodness sake, how about the TA? Everyone loves the TA. The people in in Australia love TA. I'm not a real big TA fan, multiple. I mean, I like the whole symphony. You know, it's not just saying I like the horns, I like the bassoons, whatever. You have to appreciate everything works together. And I think in the research it has been way too much of one or two or three things. The fact that everything works together. Now in the MSI world, big on the external obliques, and the rationale is because the external obliques are best designed to stabilize the pelvis. If the pelvis isn't moving too much, the spine doesn't rotate too much. And if these muscles, especially the external oblique, the multifidus, the TA, the psoas, the muscles that are supposed to, strike the psoas from the discussion, but the muscles that are supposed to actually stabilize the pelvis are working, then the hip muscles or the back muscles are supposed to move. So there's the stabilizers and the movers. The movers can move. What happens a lot in dysfunction of this area is the movers, the stabilizers are out to lunch, they're on vacation, they haven't checked in yet. Prime movers are the ones that are stabilizing it. How many people treat hip and back pain patients in their clinic? A handful. Alright, so how many patients have significant inner groin irritation? You push on the trigger points, they jump off the table. They have length tension relationship issues, they're always fired up. So me, I'd go ahead and put a dry needle in. I don't know if we can still do that in this kind of state or not, but anyways, don't tell anyone that I'm doing that. But you soft tissue treat it, you stretch it, you mobilize the joint. But what we have to appreciate is the prime movers are doing the stability. So if the stabilizers aren't working, the prime movers have to stabilize because the back has to be stable for movement. Stretching, stability and motor control. In MSI, they talk about stretching does not correct a movement. So if you have a real stiff segment, do we stretch it? The answer is not really. You do a little active stretching, but really we correct the motion, correct the movement, and we'll stretch the muscle. So if we use the proper movement strategy, the muscle will have to elongate because the body will move that. Again, the body goes to the path of least resistance. So what will happen is the body will use the tight spot. It'll go away from that and it'll start breaking down the joint. I've said that a few times. I'm gonna probably say it again a couple of times, so I apologize if I'm redundant. But this is really the concept that we're looking at. Does movement occur at the right place? If you're looking at someone moving, are they flexing where they're supposed to flex, or are they extending where they're supposed to flex? Are they rotating when they're not supposed to? Are they not rotating where they are? Does movement occur in the back, or is it supposed to occur in the hips? So many times I see patients, especially my age and above males, stiff as all get out. Younger women, not stiff enough. So the body's going to break down somewhere in between. Back to our discussion a few moments ago, are the movers acting as stabilizers? That's one of the biggest things that I treat a lot of patients who have hip pain and back pain. The stabilizers aren't working, prime movers are moving, they're acting as stabilizers, they just do a bad job. We talk about local and global muscles a lot in back pain and rehabilitation. Multifidus does a better job stabilizing, and erector spine does a better job moving. So I just thought, I think if we have the stabilizers not working and the movers trying to stabilize, all hell breaks loose. In summary, patients with lower back pain generally move earlier at the spine than patients who don't. Meaning, if you ask them to move their leg or rotate their hip, they're going to rotate at their back well before they rotate if they don't have pain. Hip lateral rotation produces early lumbar pelvic, I should have spelled that out, I'm sorry, motion in lower back pain patients. So if you have the patient sitting, and if they generally have no back pain or no history of back pain or significant back pain, as they rotate their hip, they don't rotate at their spine. If they rotate their hip and they generally have this dysfunction, they're going to twist and torque. And the twisting and torquing is really why they are in your clinic in the first place. If they're in prone and they bend their knee up, I mean, if you lay on your bed and you try to transfer, or you're moving around with normal functional activities, if you flex your knee in prone and in supine, early lower back motion, lumbopelvic motion occurs again in the cohort with lower back pain than patients who don't have it. It's kind of funny, how do they find patients who never had back pain? This is more like patients who have active back pain versus, than patients who haven't had it for a very long time. It must be non-steams or something. Training, now here's the big deal, training improves stability and function. So if you train them with motor control activities, it improves stability, improves strength, it improves their pain. And that's why they're there. They want to get stronger, they want to function better, they want to have less pain. Patients with low back pain generally have decreased hip